Thank you, the respected panelists, chairpersons, and moderators, and participants of this wonderful webinar organized by Salimullah Medical College. I would like to express my gratitude to the organizer, especially Professor Abdul Qadir Akand and Momenuzzaman, to give me opportunity to share some of my experience in handling the patient with coronary calcification. As you know, the two Achilles heel for intervention is one is calcification, other is the thrombus. So my talk is on the calcific coronary artery disease and intervention. As you know, the coronary artery calcification means that calcium are deposited in the coronary artery wall or atherosclerotic blood. That can be identified by X-ray, CT angiogram, fluoroscopy, cine angiogram, intravascular ultrasound, or OCT. There are certain factors really associated with severe calcification, especially advanced age, systemic hypertension, dyslipidemia, diabetes, chronic kidney disease, hypercalcemia of any causes, and hyperphosphatemia. Why we are interested about this? Because this is a unique part of intervention in coronary artery disease, where the plaque is very resistant, irregular lesion surface with heavily calcified stenosis, difficult to dilate adequately. The calcium often impair the balloon advancement, prevent adequate balloon expansion, impair the stent delivery, and sometimes damage the stent starts and polymer coating while vigorously trying to advancing the stent, and also prevent adequate stent expansion and apposition. So the lesion preparation of calcification before implantation has been established as a prerequisite to achieve adequate stent result, and a paramount importance of successful PCI. Usually, you know, there is commonly the calcium is deposited in the deeper layer within the media and between the external limiting membrane. Other one is the superficial calcium, usually the subintimal and up to the inner limiting membrane. And combination of these two is a mixed type of calcification. While doing intervention in a calcific lesion, you'll have to have some a special device or armamentarium in your hand to have a successful outcome, like strong backup support guiding catheter, 6 or 7, XP or M+, guide extension catheter, sometimes you need it, like Godzilla or guideliner. Hydrophilic wire easily can cross the lesion, although it doesn't give much of support, but it can cross the lesion easily. You can subsequently exchange it with a microcatheter with a stabilizing guide wire. Sometimes you need a double coronary wire as a body wire. It also extra support and has a cutting effect, especially when you use a non-compliant balloon for dilatation. To dilate the balloon with a semi-compliant balloon, especially the short balloon, you can use this angioscalp or SCORFLEX. Cutting balloon can also be used, and a very high pressure balloon like opium balloon can be used to dilate the lesion properly. And at least ROTABLATION or shockwave intravascular ultrasound, shockwave intravascular lithotripsy is another device to an extreme form of calcification which you cannot deal with the balloon angioplasty. And finally, the stent, if it's a small one, it can track easily, and it should have a adequate radial force. For mild to moderate calcification, usually I took 2 coronary wire to the targeted vessel, use a non-compliant small balloons smaller than the size of the vessel, raise the pressure slowly until the lesion dilate fully, as evident by the balloon control seen in different view on fluoroscopy as a spin mode. Repeat and prolonged inflation with NC balloon should be encouraged as the first choice in mild to moderate calcific lesions. Procedure can be done repeatedly until the lesion is cracked. And finally, 1:1 non-compliant balloon should be used to dilate the vessel at normal patient. And post-dilatation should be done on the basis of your ideal or intravascular ultrasound measurement. There is a phenomenon called Trips phenomena. It is a tendency of a solid material to move slowly and deform permanently under the influence of persistent mechanical stress. In calcific lesion, a prolonged inflation of the non-compliant balloon allowed adequate dilatation, produce a distortion force of capable of expanding a resistant calcific lesion, as shown by Crisp phenomena. These are some devices: cutting balloon, SCORFLEX, or safeguard, and angioscalp. This can be used for calcific, mild to moderate calcific lesion. Let me see one of the patients. You'll see the railroad, the calcification is the proximal LAD. That can even seen without moving heart, calcification in the proximal LAD. So intravascular ultrasound can show there is a extent of calcium almost encircling more than 180, and some places it is 360 calcification. So this is the I took the 2-wire, taken a 2.5 balloon, and dilate with the maximum rated burst pressure, spin it to see any indentation. I am seeing the small area being underdilated. So next time I'll take a small balloon and exactly focused on that particular places, go to the high pressure and keep it for quite some time as patient can tolerate. And it can be seen that the indentation has been abolished. And then put a stent accordingly to the place, and also it can be seen by spin rotational method, so that you can identify any places of incomplete apposition. And post dilatation done with a 3.5 balloon, and this is the final result. And also the intravascular ultrasound shows the stented segment is well expanded, and this is the proximal part, and slight incomplete expansion at the middle part. It was further dilated with the small size balloon, and this is the final result. Sometimes you may come across to a problem of difficult to deliver the balloon, where because of the obstruction given by the calcific nodules or something. In that case, keep two wire inside, take a bigger size balloon, not more than the size of the vessel, and further post dilated with a maximum rated burst pressure, and keep the balloon in the within the coronary. It will give an extra support, means the 2 wire and 1 balloon, so you can see that the stent deliver nicely. And also you need to see in different view to see the expansion of the stent. This is another patient with huge calcification. You can see the both proximal and mid segment. Here the 2 wire was taken and 2.5 balloon was taken. You see the balloon is expanded well. You may have a feeling that the lesion has been cracked, but if you take a bigger size balloon, this is a 3 mm balloon, you'll see that there is the area is under expand. So what you need to do, take a smaller balloon, and then you see finally it keep it at time, it will expand completely, means that it cracked the lesion. And after that you see the complete expansion of the stent without much indentation of the stented segment. So in the extreme form, what I usually practice, because most of the cases, I should say 97% cases, I used to use the method that I have described. The extreme form, I used to use the rotablation, where the usually we take a bar according to the size of the vessel, and the bar ratio is 1:2.6. And this is the rota console and the rota bar. This is a patient with a post CABG that is stented before in the distal RCA. You see the proximal and mid segment is completely calcified. You can see the whole vessel. And after this, I tried to see by IVAS, but failed to cross the lesion. Then I dilate the vessel with 2 mm balloon. Then at the proximal segment, I see that there is an indentation, means that the vessel is not been well expanded. I took 2 wire that do the same phenomena, and most of the vessel was dilated except the middle part, which is partially dilated indentation the balloon. So their next choice was the rotablation. I took 1.5 bar and passed to retriever, pass and nicely cut the calcium. This is the after calcification, after rota angiogram. And thereafter, I dilate the vessel with a bigger size balloon, keeping both the rota wire and the extra floppy wire to additional expansion, because the cutting balloon, the rota will cut only 1.5 millimeter dia, but beyond that, the calcium may not be broken by if you put a stent, but so that you need to prepare the lesion further with a bigger size balloon. And it has got an additional purpose of placing a Godzilla, because I know that I might have a problem in passaging the stent. So is another issue of taking Godzilla is that just I want to see to pass the eye burst. You see the eye burst shows almost arc completely encircle, and there are some places it was rotablated after post rotablated, and they encircle the most of the area of the endothelium. So after that, I put a stent, the distal one, with the help of Godzilla, dilate it, and again I pass the Godzilla again at the place where I put a second stent, and accordingly it was placed nicely, post dilate with the balloon, and this is the final result. If you see the pre and this is the post. Apart from this is the post stent dilatation. Apart from this, some other device which is not available in our country, but we'll have to know it about. This is an opium balloon. The high pressure balloon is a double layer balloon, and it can go up to 55 atmosphere. So most is the most successful place where normal balloon cannot, non-compliant balloon cannot open the cell, and the risk is very less, and the balloon is compatible with conventional coronary wire. This is the opium balloon. The dog bone effect is abolished with the use of high pressure opium balloon. Another is the orbital atherectomy. This is also a single size eccentrically mounted crown of centrifugal force. Its size is 1.25. It can be used for the vessel 2.5 to 4 millimeter. If it's a small vessel, then 80,000 rem per hour per minute, or if it's a bigger size, then 120. So it can cut the deeper, longer calcific plaque. This is the concept. The another one is the intravascular lithotripsy. Is also not available, but it is a promising effect use in the future in the calcific lesion. The pulsated ultrasonic shock wave produces mechanical energy to fragment the selected amorphous calcium, sparing the software. It is battery driven, and it is single-use semi-compliant balloon with 3 miniaturized lithotripsy emitting distributed along the length of the balloon. This is so in conclusion, the problem of heavily calcified coronary lesion will increase future because of the aging population, increase the rate of diabetes, chronic liver disease, chronic kidney disease. So in recent years, a substantial technological advancement in the treatment of calcific coronary lesion, an approach based on multimodal imaging technique and also use of dedicated device is a key to improve the PCI outcome. There is a higher procedural success and low peri-procedural complication with the use of combination of non-compliant balloon, scoring balloon, and sometimes you can use the other device, the rotablation or IVL. But you can avoid this technique, the technology, if you can use the modified balloon technique for the moderate to severe calcific coronary artery disease. It is better to use a small short stent, second generation DSA, to avoid restenosis, and stent antiplatelet agent should be adequate to prevent stent thrombosis. Thank you very much for your patient hearing.